Hi, everyone. Welcome. Um, I'm going to go ahead and get us started because we are right at noon and we have two speakers today that I'm really excited to have with us. Um, I'm Sarah Brewer. I co-direct our training, education, and mentorship program at Accords, and I am really excited to welcome you all today to our Accords highlights. So over the last year, we've had some changes in how we are delivering our educational programming, including integrating our education work with our training and mentorship programs under a new team core. And in reflecting on our successes and our future directions within this new core, we identified a key and ongoing need to share some of the stories and amazing work that are happening within Accords, and being led by our Accords investigators. So that's the genesis of our Accords highlights. And we want to truly highlight and share the methods, the tools, and the amazingly important impacts that our Accords investigators are having on the health and well-being of people across our clinical and community settings. So each quarter we'll highlight two Accords investigators and the work that they are doing, and we'll share lunch and discuss important research methods and findings from these teams. For those of you who may not be familiar, I do want to share a little bit about what Accords is. You see up here some of our kind of main offerings from Accords. But what are we? We are something of a one-stop shop supported by the University of Colorado School of Medicine and Children's Hospital Colorado. And we're an environment for faculty to conduct pragmatic research, receive various types of services and supports for their grants and projects, along with incredible mentorship, training, and education in health services research. I particularly want to highlight today our Prevention Research Center within Accords, and the amazing work that they do, as well as our other methodological cores and programs that are led by national experts. Before I introduce our speakers, just a little bit of housekeeping. For those of you who are on Zoom, please go ahead and use the chat throughout our session today. We welcome your comments and questions, and we have structured our day with about 20-minute presentations and then plenty of time for Q&A and discussion. So please share those. We want to engage you on Zoom. For those of you in the room, take note of those questions, hold on to them. We will absolutely be pulling you in for that discussion toward the end of our hour. And then second, for everyone in attendance, I invite you to participate in our evaluation. We take that feedback really seriously. We want to hear what is most useful for you, what topics you're interested in, and how we're doing, so that we can continually improve our offerings. Okay. And then lastly, before we dive in, from the team core, I want to just highlight a couple of upcoming events and programs that we have. So in January, we have a lot going on. Our Accords Grand Rounds, we will be welcoming Bethany Rose Dobman from Harvard to talk about palliative care, community engaged research with Native American populations. We will also have our D&I Science Graduate Certificate Program application launches on January 15th. And at the end of the month, we have our Accords CCTSI Community Engagement Forum. So January is a busy month for us. March 9th will be our next Accords highlights, and we are really excited to share ongoing research from some of our Accords fellows, from our Accords Primary Care Research Fellowship and our SCORE fellows. And then in April, we have another busy month. We have our D&I Science Researchers Workshop. We have our Accords Grand Rounds, and we'll have our last of the Community Engagement Forum series of the year, which will be our in-person community engagement for showcase on April 24th. And then lastly, I want to highlight for everyone the Colorado Pragmatic Research and Health Conference, May 20th and 21st. Abstracts are open, so if you have ongoing work that you'd like to share, please get those submitted. I believe our abstract deadline is January 5th, so January 9th. So coming up soon, but share your work with us, and we hope to see you there. Okay. I am really excited to share with you and introduce our speakers for today. First, we have Dr. Mandy Allison. She's a clinician and health services researcher with an MD and master's level training in education and public health. She has 16 years of mentorship experience with medical students, residents, research fellows, and early career faculty, as well as research services professionals. Since 2004, she's conducted T3 and T4 research focused on reducing health disparities over the life course by improving maternal, parental, and child health during pregnancy and early years of the child's life. In addition to her research and mentorship activities, she's provided clinical care to patients for 20 years. And then after Mandy, we will have Dr. Jimenez-Zambrano. She's an assistant professor in the Department of Pediatrics. Her research focuses on improving health outcomes by promoting the dissemination and implementation of evidence-based interventions in underserved populations. Growing up in Colorado, she observed health differences in outcomes across communities, which inspired her commitment to advancing public health efforts both locally and globally. Please join me in welcoming Dr. Mandy Allison and Dr. Andrea Jimenez-Zambrano today as they present studies from the Prevention Research Center for Family and Child Health, insights from the NFPx and ENRICH studies. Welcome.
This room feels very fancy and formal. So thank you all who showed up in person. And hello to whoever I can't see who's online. Oh, wrong slides. I could do these, but they're on here.
Why is Mandy's not there?
I gave George.
And they should be here. Talk amongst yourselves.
Funny things I got up here.
I thought we looked at it too, didn't we? I've done this plenty. I'll just need to come back up for Andrea's.
All right, round two. Thanks again for joining. And so I'm going to be talking a little bit more about some of the work that we're doing at the maternal and child health at the Prevention Research Center for Family and Child Health, or PRC. It's incredibly confusing. This PRC was founded by David Olds in the 90s when he came to the University of Colorado. And the reason it's confusing is because there has also been the Rocky Mountain Prevention Research Center from our colleagues at the School of Public Health. So this is the PRC for Family and Child Health, distinct from, but with some overlap and partnership with the Rocky Mountain PRC. So we're going to share insights from two pragmatic trials. I'll start talking about a project called NFPx, and I'll tell you more about what that means. And then Andrea will go talking about ENRICH. And then I just want to give a shout out to all of our team members at the PRC, some of whom are here. Thank you. So this is a couple of different pictures of us. I thought we had a good one from this summer when we had a little get together that I couldn't find. But this is a picture of some of us, including some of our family members, because we're the Center for Family and Child Health. So sometimes we like to have the families come to our parties. So Our mission is that we are devoted to fostering healthier and more equitable communities for children and families to flourish through evidence-based interventions, programs, and policies focused early in life. I'm really proud of our multidisciplinary team that includes staff members, PIs, and then collaborators here on campus, including at the School of Public Health and School of Nursing, and of course within the School of Medicine, as well as around the country and even globally. So we have a lot of expertise, including in pediatrics, caregiver and child interactions and child development, developmental psychology, maternal and early childhood home visiting is a big focus, and you'll hear more about that. Maternal perinatal health. And in fact, one of our partners who really leads some of that work just walked in, thanks. Community engagement. We really try to think about how we're engaging with the community that is involved in the research for every project we do. And under the leadership of our program manager, Carol Franco-Rowe, we've really kind of developed out a process to kind of think through that with every project. The amount of engagement varies from project to project, but we're kind of mindful about it with every project. Venice Williams leads work on cross-sector collaboration. We have expertise from the School of Public Health, particularly Greg Tung, regarding evidence-informed policy. And we have leaders with expertise in mixed methods research, pragmatic trials, and implementation science. So these are just some examples of the buckets of work that happen at the PRC. So in the area of caregiver and child relationships, there's DANCE, which stands for the Dyadic Assessment of Naturalistic Caregiving Experiences. So it's both a measure and a clinical tool to really work on caregiver-child relationships. There's Puppet Talk, which Gretchen Domek leads, which is about giving puppets, with Maria Rosa helping out a lot, which is about giving puppets to promote parent-child interactions and early language development. We have a focus in perinatal health, including our Pregnancy and Parenting Partners, or P3 program, and work in the area of perinatal workforce from our School of Nursing partners. We do work in cross-sector collaboration. We do a lot of work in partnership with Nurse Family Partnership. And I'll tell you a little bit more about Nurse Family Partnership as I go into the NFPx project. But NFP is implemented not only in the US, which I'll tell you about, but I do want to shout out that it's also implemented in other countries. So there is a team that works on global replication of NFP. We also do research related to current NFP implementation and effectiveness, and we've done things looking at like NFP client and nurse retention, as well as collaboration and child welfare involvement and Black mothers' experiences in NFP. And then finally, we do some work that's about home visiting, but goes beyond just NFP, including the ENRICH project, which you're going to hear more about from Andrea. So now I'll get into the story about NFPx. So first, just to give some context, a little bit about Nurse Family Partnership. So it's a prenatal and early childhood home visiting program that's delivered by nurses, which really gives an opportunity to do more kind of assessment and tailoring of the program, given the strength of the nursing background. It's focused on pregnant individuals, and traditional NFP is focused on pregnant individuals who have not had a previous birth, who have not parented before, and who are enrolled prior to 28 weeks of pregnancy. And the people who enroll in NFP are have overlapping adversities or risks for poor health outcomes. Those can include things like poverty, low education, young age, and chronic illness, including both mental and physical health. So NFP is really not meant to be a universal program, but more targeted for the people who are most likely to benefit from this more intensive home visiting program delivered by nurses. Since the original trials, which I'll mention in a moment, and when replication began in the US in 1996, more than almost 400,000 families have been served. And NFP is delivered in 40 states, as well as DC, Puerto Rico, and some tribal communities. So NFP has 3 big goals, and you can imagine there's a lot of mini goals within these 3 buckets, but the goals of NFP are to improve pregnancy outcomes, improve child health and development, and improve the maternal health and life course. As I just mentioned, prior to being implemented around the country, there were 3 randomized clinical trials at the NFP program that really focused in different settings, as you can see here, and in different populations. So the first trial was in Elmira, New York in the 70s. I know some of you weren't alive. I was actually live during all of these trials, in Memphis, Tennessee in the 80s, and then in Denver in the 90s. The Denver trial really focused on comparing paraprofessionals to nurses, which I think is a question that comes up frequently. And the Memphis trial is still being studied in 30-year follow-up by David Olds, the founder of NFP and the PI on all of these trials, which is pretty much unheard of in terms of that having that kind of longitudinal follow-up. So it's just really remarkable what Dr. Olds created and the trials that he originally conducted and has continued to this day. So NFPx stands for the NFP Expanded Eligibility Initiative. So I pointed out that kind of traditional NFP is focused on first-time parents and those who enroll before 28 weeks, and NFPx is allowing enrollment of pregnant people who've had babies and who are enrolled later in pregnancy. They still have to be enrolled during pregnancy, but they can be enrolled after 28 weeks gestation. And you'll see that those go together a little bit sometimes. So there are reasons why David Olds designed NFP the way he did, and there are biological and behavioral reasons why we think NFP may be different, particularly for people with previous live births. I'm not going to go into these foundational theories of NFP, but just to point out that within each of these theories, human ecology theory, attachment theory, social cognitive, and specifically self-efficacy theory, as well as what we know about biology and neuroendocrine changes that happen during pregnancy, we have reasons to think that maybe NFP needs to be adapted or may work differently for people who have had previous births. So, Dr. Olds and colleagues, Nancy Donnellan McCall, who's still a very important contributor and the leader of DIADS at the PRC, as well as others, you may recognize your names on here, came up with this kind of NFP model for innovation development. So it starts with understanding the program challenges, doing formative development, then pilot testing of the intervention, then rigorous testing, and then translating that learning into practice. And I added the arrow on there because, of course, you know, it's not so linear, right? You're always kind of reassessing, learning new challenges, and circling back. So this is kind of the model that we used for NFPx. The program challenge that we were facing was this desire in the communities for NFP to serve a broader population. And so that's kind of what got all of NFPx started. So prior to this study, I'm going to tell you a little bit more about. We conducted a formative study, and then 2 pilot studies. So this was probably what ended up being the biggest formative study I've ever seen. because it ended up involving 35 teams in 28 states, or in 28 NFP sites in 15 states. And I think mainly that just speaks to the kind of problem that we were addressing, which was this desire among communities and sites administering NFP to expand the population that they were reaching. And the big things we learned from that formative study, and I'm not going to go into detail today, were about the feasibility and acceptability of NFPx, so serving these additional populations, as well as what was needed. And one example was, for example, clients with previous live births who had other children in the home needed more care coordination. And so we made recommendations, and many NFP sites serving multips, people with previous live births, added a care coordination role to their team. As one example, the nonprofit that delivers NFP around the country, now called Changeant, developed education to support serving multips based on our learnings from that formative study. The next study that we did was led by Greg Tung, and it was a quasi-experimental design pilot study that really built on or kind of leveraged 3 different formative study sites that were all embedded within a health system. So we were able to partner with those sites and their health systems to compare people with previous live births who were NFP clients. So from here on out, I'm calling them multips because it's easier. It's short for multiparous. So we compared multip NFP clients to similar multips who were covered by Medicaid within that health plan. And we found that NFP sites did successfully enroll multips with risk factors for poor outcomes. So they had a lot more risk factors compared to the general Medicaid population served by those health plans. In that study, we did not find that NFP improved birth outcomes, but there were some problems with that because we weren't able to account for things like previous preterm birth, previous gestational hypertension, which are known risk factors for subsequent preterm birth and gestational hypertension. But we didn't have data going that far back necessarily for this population. We did find that participation in NFP was associated with increased receipt of postpartum visit, recommended at 6 weeks postpartum, as well as recommended well child visits. The Florida pilot study was also focused on sites that had kind of signed up to participate in the formative study, but really focused on late registrants and late referrals. And we found that, sure enough, those who were referred, so not necessarily enrolled in NFP late, were more likely to be multips. They were more likely to receive late prenatal care. They were more likely to report being smokers, and they were more likely to be immigrants. Once late referrals were enrolled in the program, we called them late registrants, and not surprisingly, they had fewer visits during pregnancy, but better retention at 12 months and similar better rates of screening compared to those who were enrolled, quote, on time. And then finally, compared to those who were enrolled on time, program outcomes were similar. So I think a really interesting question from this is, we're doing this project in partnership with Changeant, the national nonprofit. And the question is always, so when do we have enough data to decide if expanded eligibility for NFP should become standard of practice? And so the final part of my presentation, where I tell you a little bit of a story about this project, really gets at when do you know you have enough evidence, and how do you generate enough evidence? So, we did our formative study, we did our pilots, so we were ready for rigorous testing. So when we started planning to do this rigorous testing phase, we started with, well, so what did we know that we didn't know when we started the formative study in 2017? We knew that NFPx meets this community need that was desired. So it's reaching the people at risk for poor health outcomes. And we knew that serving multips and late registrants in general is feasible and acceptable. Yes, there are challenges that we identified, but we identified ways to support teams in meeting those challenges. We learned the requirements for meeting those challenges. We found that NFP was associated with increased receipt of preventive care for multips. And then we found that NFPx didn't appear to affect, quote, standard NFP delivery. But there were still a lot of gaps. Most importantly, we really didn't know much about the impact of NFP for people with previous live births or multips, specifically for things that you really can't get from birth certificate or health plan data, things that we know are important based on some of the community engagement work we've done, including maternal stress, or kind of the flip side of that, maternal flourishing, birthing and the postpartum experience, tobacco and other substance use, parenting in the home environment, injury prevention for the index child, which was a big finding from the original RCTs led by Dr. Olds, and behavior and development of the index child. We also don't know much about the effect of home visiting on siblings in the home. And that's true for NFP. That's also true for the other home visiting programs like Healthy Families America, Parents as Teachers, that are implemented around the country. Everyone kind of focuses on that index child and hasn't looked much at outcomes on siblings or other family members. And then finally, based on that, we don't know return on investment for this expanded population. So we eventually got funding from NINR to do a randomized clinical trial of NFP's impact in Ohio. And this is the original study design, and I'm going to tell you a bit of a sad story. So the original design was to recruit 500 pregnant people in partnership with sites in Ohio. You may ask yourself, you're in Colorado. Why Ohio? Well, because the governor of Ohio had decided to expand home visiting, and in particular was interested in funding and expanding nurse-family partnership. But that expansion was going to require that they be able to serve multips. So we thought, wow, this is a great opportunity. They're going to expand to multips, but they're not going to have enough capacity to serve all the multips at once. So there'll be wait lists, and we can randomize people from a wait list. And that will be acceptable to everyone. So in conversations, it seemed like that was going to be acceptable to everyone. I think you could probably see what's going to happen when I tell you the sad story. We had planned to do 7 data collection visits starting at baseline when they were enrolled during pregnancy through child age 24 months, and look at several outcomes that fit those buckets of what NFP has been shown to do in the original trials. Okay, so here's the sad story. We had lots of struggles, which I'm going to share in the next slide, and we actually lost our funding from NINR, which it's like hard for me to even say publicly, but I'm doing it as a public service. If you are in that space, you can come talk to me because I understand. And we survived. So some of this story is about being creative and moving on and being resilient. So this is a very, I could tell the story for a really long time, but I'm going to try to not. So this is a very brief summary of the challenges that we faced and why the RCT ended. So first thing was challenges to individual randomization. We made this great plan. We submitted this grant. You don't get funding till more than a year after you write the grant. And by then the landscape was changing. The landscape was changing in Ohio. The governor's focus was changing. The planned expansion of NFP and the capacity was changing. In addition, a big healthcare system that we were planning to partner with decided that enrollment in NFP was going to be one of their quality metrics, which then meant they were absolutely not okay with randomizing, right? Because referrals, and it's actually referrals to NFP that were in their quality metric. So then we're like messing with their quality metric. And also enrollment in NFP overall was lower, and the timing of the expansion had changed so that we weren't going to be able to meet our numbers for recruitment at the existing sites that we had in Ohio. So Mike Knutson, our lead biostats at PRC, is in the audience and knows that we spent a lot of time talking about a variety of different study designs, knowing that an RCT is the gold standard and realizing that we weren't going to be able to do it. So we talked about some kind of rollout design, we talked about some kind of cluster design, and we eventually ended on a quasi-experimental design. We also had challenges to recruitment. I mentioned a little bit where overall kind of the expansion of NFP was lower, and then enrollment in NFP was a little less than expected. And so we ended up solving this problem by increasing the number of recruitment sites by switching to remote data collection. So switching to remote data collection had its own set of learnings. In particular, we were also trying to do this in both English and Spanish, and when we were trying to measure child development using objective measures. Again, that's really like a whole other talk. Another challenge was the time required, right, to measure child development outcomes for interventions starting in pregnancy. So NFP starts in pregnancy, the baby has to gestate. The child has to develop, and you can't measure child language development meaningfully until they're at an age at least around 24 months when they're expected to be demonstrating their language. And so that makes the timing really challenging, and there's just not much you can do about it. So what we did is we ended up shifting our primary focus more to caregiver-child interaction measures, what we know is kind of a mechanistic requirement for promoting language development. And then finally, the expense. RCTs are really expensive. And we manage this by ending up with a different sample size, a smaller sample size, which means we had to change our primary outcome sum. For example, initially, one of our primary outcomes was reduction in smoking, because we know that multiparous families are much more likely to smoke than primiparous families enrolled in NFP, but because still only a subset of people smoked, that could no longer be a primary outcome with a smaller sample size. We also moved to a shorter timeline with fewer data collection visits, and then less expensive measures. And by expensive measures, sometimes you do have to pay for copyrighted measures, but really it's the staff time to collect the measures. And this is just a quick slide showing kind of all of the research methods that we kind of talked through, from experimental designs to quasi-experimental designs to kind of different non-experimental methods, and how we could salvage this study. Again, there's a whole other talk about all these different methods, but just we talked through these. And it was an opportunity to get creative. So we now have a revised trial that's funded by philanthropy in partnership with the nonprofit who's remained invested in understanding NFP for multips. And as I kind of mentioned in the challenges slides, it's a smaller sample size with fewer data collection visits and fewer outcomes. We did do a couple of things to try to maximize the validity of a quasi-experimental design, because obviously one of the big limitations of a quasi-experimental study is selection bias and who ends up getting the intervention and who doesn't. And it still makes me really sad, actually, thinking about that selection bias. And wish that we could have come up with some randomized situation, but I really don't think we could. But we are doing these things. So we're making sure that the program and the comparison groups are highly similar at baseline, and that includes recruiting NFP participants and similar people from matched geographic areas and matched referral sources, and then using baseline covariates so that we can compare people at baseline. And then for some of the outcomes, we're able to measure before and after the intervention is delivered. We're pre-specifying our study design and primary analyses. We're collecting our outcome data in the same way for both groups. And then we're trying to follow all the rest of the same practices that a well-conducted RCT would do, including things like preventing attrition, making sure that we have good retention in the study and doing an intention to treat analysis. So I put this up here partly because it makes me feel better about my failed RCT, and partly because I feel like this may be instructive for others thinking about how do you maximize the validity when you've had to do a quasi-experimental design study because of all kinds of circumstances, many of which I feel like I have now experienced. So it's Andrea's turn. Next step for us is we're going to finish this study, and I hope to return to you and tell you a little bit more about it. And now Andrea is going to come tell you about a different pragmatic trial that's not quite such a sad story, maybe.
Lovely. Till now it didn't share.
Okay. Hi, guys. Thank you for being here. I'm going to be talking about the ENRICH study, which was funded in 2022 by NIH. And it's a 7-year grant. It's a UG3 UH3 grant. And it stands for Early Intervention to Promote Cardiovascular Health of Mothers and Children. And Mandy is the MPI with Kate Sutter, who is now at Wake Forest. And, and there you go. And I am the early stage investigator, and I also function as the implementation scientist in the team. So what's ENRICH? ENRICH is a program that aims to test the effectiveness of an implementation-ready intervention designed to promote cardiovascular health and address health disparities in both mother and children. And it's specifically focused on participants who are of low socioeconomic status, who live in a low resource area, either rural or urban, and also who are located in different regions with high burden of cardiovascular risk factors. And this is where NFP comes in, right? So when the program was funded, we all know that evidence-based home visiting is really effective and it has a great impact on families. So what they did was they partnered with these 4 different home visiting programs, and they added this program to see if adding this specific programming to this already effective home visiting programs could make a difference. So here in Colorado, we are doing NFP, but across the country, we're partnering with Family Checkup, Healthy Families America, and Parents as Teachers. So who's participating in the study? There are a total of 7 different clinical centers. Here you can see 8 because our other MPI moved to Wake Forest. So we have CU and Wake Forest as a site. But we are not only working with the programs in the states of the research clinical centers, but we're also partnering with other states. So we are doing this intervention all across the country. So what are the primary aims of ENRICH? So first, we wanna evaluate if there is a difference between clients receiving this ENRICH intervention with those that are receiving just the standard of care home visiting interventions. And then we're gonna look at if there's any difference in diet, physical activity, BMI, and also blood pressure. And we're gonna do the same thing with their children. So we're gonna compare the BMI of people who have mothers enrolled in the ENRICH intervention versus those that receive regular home visiting. So as a part of the secondary aims, there is an implementation study, and we're trying to answer 3 different questions. As you guys know, it's not only important to look at the outcomes, but it's also important to study how the intervention is actually being disseminated and how it's being implemented in the field. So we're trying to answer, the implementation study is trying to answer 3 different questions. So the first one is around dose. How are the components of the intervention? What components of the intervention are being delivered and how much? Also, what is the context of the different agencies? And also, how are the supervisors and the nurses adopting the intervention? And here on the right, it's kind of like a busy table, but basically what this is trying to show you are the different types of data that we're collecting. And all of this is heavily quantitative data. And we're collecting it from just the home visitors and also the supervisors. Oh, wrong way. There it goes. So like I mentioned, this is a 7-year study. So we are already on the full trial phase, but the years 1 and 2 were focused on making sure that the materials were integrated, and also we're gonna be applicable to the home visiting models. We talked about recruitment and data collection. We also did a pilot just to understand how it was going to work in real life. And also, because it's a consortium level grant, we needed to make sure that all the protocols and the intervention were harmonized. And in the now in the full trial, we're recruiting participants. Participants are either randomized to control or intervention, and then participants stay in the program up to 24 months postpartum, and we're doing outcomes data collection at 12 months and at 24 months. So this slide is showing all the different components of the actual intervention. And this slide was developed because we wanted to help our home visitors navigate the intervention, which can be pretty complex. So we created this graph to kind of guide the nurses. And what's pretty cool about this intervention is that you start with letting the clients tell you what they want to focus on. So you do what's called know your health assessment prenatally, and participants can choose whether they want to focus on physical activity, healthy eating, or weight, or topics like smoking or mental health. So depending on what the client wants to focus on, then the nurses have just a wide range of information to provide to the clients, in addition to what they, provide usually as part of NFP. Then after they deliver, the nurses go back to the client and ask the same thing, right? Because you can imagine that priorities and the focus of mothers change. So they just want to know whether you want to keep working on the same goal or you want to focus on something else. We do a couple of blood pressure checks, and then we also have modules for the children or for the child, the focus on child development. So just an update on where we are. So we have been recruiting for about 1.5 years now. We've recruited a total of 140 clients, and we've collected data collection on 127 people. As of last week, we had 20 participants who have completed the 1-year follow-up. So we're getting there. But now the other side of this presentation for me is, as I mentioned earlier, I am an implementation scientist, and the parent trial was heavily focused on quantitative measures of implementation. So those measures tell us the what, right? Like, what are they doing? Are they delivering the entire intervention? Are they focusing on specific pieces of the intervention? And my interest is more on the how and the why. So what I did with Mandy is we put together an ancillary study to understand social drivers of health in this population. This study is currently funded by the Ludeman Center, and it's a pilot study. So this is a little bit of background, but I think I'm running over. So you guys all know social drivers of health are important when thinking about cardiovascular health. And although we know that it's important to take into account what social drivers of health do to how people live their life. I think we don't understand how social drivers of health impact participants' ability to engage in an evidence-based intervention. So I just wanted to learn more about that. So this pilot study has two aims. The first one is to understand what social drivers of health look like in our baseline participants. So and I'll talk more about what I'm gonna do. But the second aim is just to understand this how, based on what their social drivers of health look like. How are they able to engage with the intervention? How are they receiving the advice and the information that they're getting from the intervention and from their nurses? Okay, so there's a typo here, guys. I'm sorry. I think we fixed it, but not in those ones. So my apologies. We always need a theoretical framework or a model to guide how we answer questions. So for this study, I used the critical framework of social determinants of health, which thinks about participants and clients, humans' everyday experiences of not only structural determinants, but also their lived personal experiences. So in this study, I'm focusing on just trying to understand more how their demographics, their food environment, their social risk influences how participants live their life, but at the same time, how are their lives interacting with the intervention? So because we needed to understand more about the context, I decided to also use PRISM, or the Practical, Robust Implementation and Sustainability Model, which is an implementation and dissemination model. And I think this model is very helpful in understanding the context, but not only the context of the participant, but also the context where the intervention is taking place. So for this, I'm going to be looking at patient characteristics, which, like I mentioned earlier, are demographics, external environments, so how resources and political situations might be impacting how participants are living their lives, and also their perspectives on the actual intervention. So I'm using those two frameworks and models to answer my questions. Then this is a little bit of a complicated and busy slide, but basically what I'm trying to show is that I propose to do an explanatory sequential mixed methods design, meaning I have a quantitative aim and a qualitative aim, and I'm integrating them along the way. And I think that this approach is trying to ensure that the exploration of social drivers of health does not only focus, like I mentioned, on the what, but also the how and the why. Okay. Oh, sorry, guys. There you go. So for quantitative data collection, these are some of the measures that we're collecting as part of the parent grant. So there are some measures on food insecurity, nutrition, discriminatory experiences, childhood experiences, as well as socio-ecological factors. And then at the same time, we're looking at baseline survey variables like education, income, insurance, household composition, and marital status. So what I'm gonna do is I'm gonna look at this data and what this looks like for all the participants enrolled at our Colorado site. And I just want to know whether there is high food insecurity, where there is discrimination, what that data looks like, and then I will work on creating an interview guide, which actually my wonderful analysts have already started to draft, to tailor it to what our participants need. So the second aim is to conduct semi-structured interviews with participants who have been a part of ENRICH for over a year, who are older than 18 and who speak either English and Spanish. So we're gonna do it in 2 different languages. And we're hoping just to understand more of the how and the why. And I don't have specific questions to show you just yet, because I haven't looked at them just yet. But I created this kind of word cloud just thinking about things that I'm gonna be asking related to their experience with the program, their experiences, languages, their community, social situations, and how they are experiencing the program within their, their lives. So as far as next steps, I'm going to start working on the quantitative data analysis and finalizing the interview guide. We're hoping to start recruitment next month, and then start doing some interviews. And I think one thing that I didn't mention is this, like I mentioned earlier that this is a pilot study, but the idea is to do more implementation to learn more about the how and the why across the entire consortium. So we're going to work on put together with other colleagues at different clinical centers an RO1 just to understand this a little bit better across sites and also across different home visiting programs. And yeah, that's what I have, guys, for you. Thank you so much.
Thank you both so much for sharing about all the many parts of your NFP and PRC work. I would love, Mandy, for you to maybe expand a little bit on your sad story turned happy story of maintaining your study and what some of those conversations looked like in pivoting, in continuing to engage all of your partners, and kind of keep that study running under a different framework.
Yeah, no,
there you go.
Yeah, so I think a couple of things. One, I think maybe one lesson learned was we had a parent advisory board for this study. We had engagement with the NFP nonprofit for this study. And I think having those relationships in place when we had to transition really helped us kind of be resilient and flexible and figure out how to make the best of things, I guess, because we could draw on those partners and their expertise to kind of talk through different options in addition to talking through it with our study team. And, honestly, that whole scenario of kind of one thing after another that was making the project challenging and pivoting wasn't all at once. I tried to consolidate it for you all, but honestly, it was happening over a 2-year period, right? And so kind of all of those challenges were separate conversations. But I guess if I were to give advice, it would be when your research is grounded in partnerships, I think that not only is the research better, but when you do face challenges, it offers flexibility and opportunities for resilience. So that's how we were able to get additional funding through philanthropies, through Change In, the nonprofit, because they were really invested and involved all along. And for example, when we switched to remote data collection, there were just a lot of things we had to work out with that. Again, that could be a whole separate talk, but the parent advisory board was really helpful in working through a lot of the kind of decision making surrounding remote data collection and what would and wouldn't work. And it would have been really hard to kind of redesign without their input.
Mm-hmm. Do we have questions here in the room? I welcome them on Zoom too. I have not seen any come up on the chat yet. Yeah.
Hi, Bree. Thanks for coming. Bree's one of our PRC PhD nursing partners.
Here you go, Bree.
Thank you so much. And thank you for your candor sharing this, because I think we can all benefit from sharing our vulnerability in this space. In your presentation, you talked a little bit about some of the limitations with NIH as far as timing from submission to funding, those issues. And I'm wondering kind of if you have sort of a list, and I don't want to kick NIH while it's down, but when we have an opportunity to be rebuilding in the future. Some of the limitations of NIH that adversely affected this study. What were some of the bullet points there?
That could be a loaded question, but I will say that our partners at NIH were great in trying to work things with us, right? Like they were in a tight spot themselves. I think one of the really big things that we came across actually had to do with language. So a lot of the NFP sites we were working with serve people who speak a lot of languages other than Spanish and English. And there's so many challenges, as Andrea and others in the room know, about conducting multilingual research, and the funding, it just takes more money and time. And so like some sort of increased emphasis or accommodation in terms of money and time for conducting multilingual research, I think would be something I'd love to see happen at NIH. I'm a total believer in peer review, right? It'd be lovely to have things move faster in some way in the timeline while still maintaining the rigor of meaningful peer review. Those are two big thoughts I have. I'm sure we can talk about more, but those are two big ones.
Andrea, I'm wondering if you can speak a little bit to conversations you've had or considerations you have around the social drivers of health. It's a question that's come up in several of our education programs around sort of the ethics or the process by which we collect that information, and whether or not we have resources available or policy levers available to change those things. And so how you've thought through those for your implementation work around social drivers in the ENRICH trial.
Yeah, I think for me it was important that we were collecting that data in the parent grant. So there was a lot of discussion prior to me designing my ancillary study, and I knew for a fact that I didn't want to ask any additional questions, so I was just working with what was available. And I think to think about just the impact of asking those questions from your participants over and over again. So just being mindful of what you're asking, how you're asking, when you're asking, and that there are people answering those questions, right? And also, like something that Mandy mentions all the time when people are like, I'm gonna add this measure and I'm gonna add this other measure. She's like, but what? I see you shaking your head. But what's the reason for that? Like, what are you gonna do with the data? It's not, it's not enough to say, I think it's super interesting to know their ACEs. Well, no, let's talk about what's behind that, and not just collecting data to collect it because it's so interesting. I mean, as scientists, we think it's super interesting to have all this data, but then we need to think about, our participants and our clients.
Yeah.
All right, the last few minutes here. I had a big picture question about how the Prevention Research Center thinks about including other family members. So I heard you talk about siblings. I think that's amazing. How about the second parent, if there is one in the home? How do you think about that in that bigger picture of just the family?
Great question. Very perfect coming from you, given that that's such an important focus for your research. We had, when we did our Florida pilot study that I mentioned just really briefly, we again had a group of parents who were involved in that study, and that time we explicitly recruited a father. And I can't just say, his name was Devin. I can't say enough about what Devin had to contribute to kind of getting us to think about that. And honestly, I think it's an area that you should probably keep pushing us on, that we haven't done enough with. I know that Nurse Family Partnership and home visiting programs like PAT and HFA have started some initiatives like through the Home Visiting Applied Research Consortium, or HARC, looking at other caregivers and parents. I'll also give a shout out to Puppet Talk. So the program that Gretchen Domek leads with support from Maria Rosa Gasparo, where they give puppets, because they've really learned and really started to focus on when they give this puppet, which is this really simple intervention. What they found that really stuck with me is how many other people in the family use that puppet. So they can show you data where they've done follow-up surveys and they have a graph, and it's like exponential. It is so cool. One little puppet, and it reaches, like, on average, not counting the infant, 4 or 5 other people in the household. So I would say that, Puppet Talk has enabled us to answer, is pushing that area a little bit about thinking about other people in the family. And then Nancy Donnellan McCall, who's a developmental psychologist who leads the work with dance and caregiver-child interactions, is working on writing some other grants, developing some other research that's looking a little more deeply at the family dynamic. But I think that that's a place where we need to go, that we haven't gone so much yet, but keep asking us and pushing us.
Thank you both so much for sharing about both of your studies, all of your work today. And thank you all for joining us. All right.